Hello again, my name is Valeria Ferrari. Thank you for being here. So as you know, I'm the general manager of Teton Company. And today is a very important day for me because it's the first webinar with Dr. Scott Green. I will do a short introduction of Dr. Scott Green, and then I will leave him the word because this webinar will be really, really interesting, and I will not to waste your time. So Dr. Scott Green received a DMD degree from Tufts University of University School of Dental Medicine and a Master in Science in Microbiology from Montana State University. He has been in a private practice general dentistry in Montana for more than 30 years. And much of the Dr. Green practice has been traditional general dentistry, and he has seen patients of all ages. Dr. Green works with the latest technologies from diagnosis through the end of treatment, including lasers, digital imaging, CAD/CAM design, and measurement technology to identify underlying problems, determine treatment endpoint that is so important, and also help patients get more comfortable with their new dentistry. Dr. Green's primary area of focus has been treating and teaching modern diagnosis of treatment for TMD, 8H, bite problem, jaw pain, and also obstructive sleep apnea. So Dr. Green uses a number of different technology, and today we will see an example of them, an alternative medicine product to make accurate diagnosis and guide treatment, providing quality modern dental care, including Teton. So thank you, Dr. Scott, for this opportunity. It's so important for us, and I will ask to all attendees to ask the question in the Q&A section. I will read all the questions at the end of the webinar in order to not interrupt the doctors. So thank you again for being here, and let's start.
All right, thank you, Valeria. I appreciate it. And thank you to all of you who are joining us today. We have participants from all over the world today, so it's very exciting for me to be talking to you about this new exciting technology that's something that's available to all of us. This is a little bit of an outline of what we're going to cover today. We're going to look at EMG, how it fits into a modern dental practice, using measurement technology so that we can provide the best quality care for our patients and for them to be most comfortable to protect our dental materials. We're going to talk a little bit about basic concepts about occlusion. We're going to talk about some of the different technologies that are available that I use to help in my diagnosis and treatment. We're going to look at how Teton and EMG is a very important tool, both in diagnosis and finishing our cases. There's a specific neuroanatomy of occlusion that I'm going to try to introduce to you. And then clinically, I want to be able to correlate Teton with what we're finding using other technologies in the mouth so that we can create the best results. As a disclosure, I don't work for Teton. I don't work for any other companies. I'm a private practice dentist. I see patients all day. I do education. I'm involved with other people giving education. So I do work with other dentists as far as educating people, but I have nothing to do with sales of this product or promotion of this product. I'm just here to educate you and try to integrate the ideas of why EMG is important in a modern practice. So I'm going to start with some very basic concepts, and hopefully this is mostly review for you, that this is not something new, that you're not hearing this for the first time. And a lot of this that I'm showing you in this first section is right out of Dr. Pete Dawson's book, Functional Occlusion. So using the standard of what our industry uses for designing occlusion and considering occlusion. So Dr. Dawson says that teeth should come together, simultaneous, equal intensity contacts on all teeth. Simultaneous, that means all the teeth should come together at the same time. Equal intensity, all the teeth should come together with the same force. So we're going to look at time and force of contacts and how this affects the muscles of the face. Now, as teeth function, there is a time component. If we look at the image on the right, if the teeth are lined up perfectly and the supporting cusps fit into the opposing fosses, the teeth will fit together in a very short amount of time. But as people function, if we look at the chewing cycle, people move their mandible to one side as they're chewing, looking at the envelope of function. We see that the opposing cusp, in this case, the buccal cusp of the mandibular tooth, is hitting the inclined plane, the lingual inclined plane of the maxillary tooth. And it takes time for that cusps to slide along each other until they fit into the fossa. So this time component, how long does it take for these teeth to fit together, affects the physiology. This is from Dr. Dawson's book as well. And so he suggests that we actually decrease this amount of time by reshaping the teeth, or what he calls occlusal equilibration, so that the teeth fit together with a better time component and a more balanced occlusion. What we need to think about is that this is also can be very damaging, that when a contact is on a cuspal incline, there is a vertical component pushing the tooth up into the fossa, but at the same time, there's a horizontal component. And this horizontal component can be very damaging. This is what causes painful teeth. This is what causes painful muscles. Teeth break, broken dental materials, that we need to get the teeth to fit properly and to prevent traumatic occlusion. And as I'm going to show you, the teeth-in is what's going to show us whether this is working or not. This is where we want contacts to be. And as I said, this hopefully is review for everybody. What we're seeing is supporting tooth contacts on the supporting cusps, marginal ridges, central fossas on posterior teeth. These are our guidance lines, with guidance being the patient moving into an excursive position, or functionally when they're chewing, that their guidance should be on the anterior. So we should see lines on the anterior, and we should see dots on the posterior teeth with articulating paper to see where the teeth are fitting together. This is the standard of care in our industry. This is something that all of us do every day in dentistry. Okay. This is what it looks like in the clinical situation. Contacts on cusp tips, supporting cusp tips. This is the maxilla. We can see that the lingual cusp tips, the palatal cusp tips are supporting, central fossas, marginal ridges. We don't want any contacts on inclined planes. Contacts on these inclined planes are going to be functional. Either they're occlusal interferences, that when the teeth come together, that something's in the way, or they're going to be balancing or working interferences as patients occlude as they go through their different motions. Now, this is something else that most of us don't think about. But this is out of a text from originally from the 1940s from Dr. Glickman, who was a very famous periodontist. And what he says is that when a force is applied to the tooth, that there are two characteristic phases of tooth movement. First, the movement of the tooth is within the periodontal ligament. So there's a redistribution of fluids. The tooth moves through the periodontal ligament, and then ultimately it buttresses up against the facial bone or the lingual bone, and it causes the plates of the bone to move a little bit. The markings here show that the T is a tension side, the P is pressure side, R is the axis of rotation, and then the opposite motion happens at the root tip. So there is tooth movement inside the periodontal ligament. Now, there's a space in the periodontal ligament space, and those of us in general dentistry, look at these things as we're looking at our radiographs to see, is there a wide periodontal ligament space or a narrow periodontal ligament space as it's been damaged? The other thing that I'm going to talk about is there are sensors inside this periodontal ligament space, neurologic sensors that affect the occlusion, and I'm going to talk a little bit about that later. Okay. This is some early work that was done with EMG. This is an early EMG, and this was done by Dr. Robert Kirstein, who has done a lot of research with digital occlusion using a number of different technologies. He works mostly with T-scan, but also T-scan and EMG. And what he found is that there's a difference depending on the occlusal pattern. He calls something long disclusion or short disclusion. The definition would be from the time a patient bites together and they move into an excursion, we want to see cuspid guidance. How long does it take for all the other teeth to come apart? Patient bites down, moves into a left or right lateral excursion. How long does it take to be only on their incisal or cuspid guidance? He calls long disclusion time. This is, early. In this case, this is a long disclusion time of 1.39 seconds. And he found at this point, he was calling short disclusion time less than half a second. Now, we measure using the T-scan. So a lot of the stuff I'm going to show you is using T-scan measurement technology. We're using measurement technology with the T-scan. We're using measurement technology with the EMG, as well as other technologies that we now have. He's refined this now to look for even a quarter of a second in our exclusion time. But what we're looking at here is some old technology. This is looking at the masseters, the left and right masseters. You can see there's two red lines and two blue lines. The red is long exclusion time. So the patient bites down. Okay, this is microvolts on the vertical axis and time on the horizontal axis. Patient bites down, holds their teeth together, and then they go into an excursion. And in the excursion, we see that that there's less force because you can't bite down hard when you're going into excursion. And the excursion takes a long time, and there's muscle activity through the whole time. And it takes a while to get back down to resting value. So resting value, clenched together, excursion, and then a long time, and the muscles relax. What we see with a short exclusion time, and it's not time synchronized, is but they bite down, they hold their teeth together. Here's the excursion, they very quickly come apart, and the muscles go to resting values. So what we're seeing is that the longer it takes for the teeth to come apart, the more muscle tension. We're talking about muscle tension because that's what Teton measures. Teton measures the amount of microvolts, the energy in the muscles. And it's not only how much time does it take for there to be muscle activity during a function, but how quickly does it get back to resting values. The longer that the muscles are tense, they use up more ATP in their physiology, they become more fibrotic, there's lactic acid, there's all the damage of muscles from long time use. Look at the long distance runner versus the sprinter and how that affects their muscle physiology. So the fact is that the tooth contacts affect the muscles and create the muscle tension, which creates the discomfort for the patient or damages the dental materials. And notice this research is from 1991. This is not new. This has been around for 30 years. It's just taken our industry some time to realize that this is an important parameter that we can now measure to help us determine if we're successful or we're not successful. And so if a person has unbalanced occlusion, there's lots of damage that gets done to the teeth themselves. And I'm not going to read the entire list. I'll let you read the list, but these are things that you see every day in a dental practice. Tooth wear or movement, damage to dental materials, damage to the teeth themselves, bite changes, muscle change, TM joint damage. And so we need to try to look at these things when we look at our patients. And these are the symptoms that people present with. They tell us that they brush their teeth, that they are bruxist, and they grind their teeth, or they have trigeminal nerve pain, or headaches, or facial pains, eye strain, earaches, lots of damage that can be done. And this is not a course about TMD problems, but these are things that you're going to see every day in your practice. We live in a digital world of dentistry these days. We use the computer for most of the different things that we're doing, from marketing, patient communication, patient records, our imaging, caries detection. If you're not using caries detection technology, it's something you need to look at. We do digital case design, smile design, optical scanning. We mill, we print our cases, and then we finish our cases with articulating paper. So we're doing everything in an objective digital world, and then we finish the case in a subjective world. We say to the patient, how does it feel? And half the time the patient says to us, it feels great because they're ready to leave. They figure they're going to get used to it. And you know that's not the case, and they may be back. And so if we're doing bigger cases, if we're doing numbers of crowns and bridges, if we're doing post-orthodontic adjustments, patients are not always able to tell us if they're feeling good or bad, partially because the teeth are moving and it takes time for things to settle back into place. So today I'm going to talk a lot about diagnosis, because that's something that we don't always spend the time that we need to. So, and I'm talking here about dental diagnosis. Obviously, we look at the oral cavity and other things, but when we're looking at the teeth themselves, we look for these things every day, every patient, every hygiene check. Every time I see a patient come in, I talk to them about signs of dental disease. Do they have caries? Do they have open margins on crowns? Are there broken cusps? Talk about periodontal disease. We measure pockets on every patient. We look for inflammation and bleeding. And we talk to patients about signs of occlusal disease. Wear and tear on the occlusal surfaces, exposed dentin, cracked restorations, gingival recession, abfractions, all the things, mobile teeth. We talk to patients about this every time because as dentists, it's our job to educate our patients. And so what do we do when we look at this? What are we doing now? How are things working in the analog world? Okay, and how are things working in the digital world? Digitally, we start all our cases with imaging. We take cone beams on most of our patients these days. We take full mouth series on all of our patients. In the US and around the world, we work with dental radiologists. Yes, we read radiographs every day. We read CTs all the time. In the US, I give a lot of credit to a group called beam readers. These are dentist anesthesiologists or dentist radiologists. They have dentists licensed in every state in the US. If you're not using beam readers, this is a very important step, reading your MRIs and CTs, especially from a medical legal standpoint. The radiologist will make the diagnosis. The radiologist will tell you what's going on with your scan. I read CTs all the time. We take CTs on most patients, and the radiologists find things that I miss most of the time. But from a medical legal standpoint, I have the radiologist making the diagnosis that if it turns into something legal, that I have that background. That behind me to protect against any damage. We look at muscles with EMG. Now, yes, we still palpate muscles. We still look for trigger points. We still look to have patients report what's uncomfortable. We look at the teeth with a T-scan. We use articulating paper as well, but the T-scan is digital. It allows us to analyze it. We can see changes. We can quantify things and look at changes from visit to visit. We analyze our joints with something called joint vibration analysis. Because it gives us a digital readout and we're able to tell, is this person have some sort of joint problem? And if a person has some sort of joint problem, you should know that before you start treating the case. If you're doing 1 or 2 restorations, that's not a big deal. But if they come in complaining about headaches, or they complain about moving teeth, or they complain about things don't feel right, you need to be able to document what's happening. And it takes just a few minutes to be able to do that. We do some psychosocial analysis. We use a form called a HIT6 form where patients let us, it's a tool that we use to document, does the person have headaches and is it affecting their life? But we also do all the traditional techniques. We're integrating technology into the traditional techniques to give us better results and to give us better outcomes. And so we do take complex patient histories, and we do muscle palpation, and we look at range of motion and arc of closure and all those things that hopefully most of you are doing today. This is a very important slide if you are doing TMD, and if you have I'd suggest you do a screen print of this, or if you have your iPhone sitting next to you and you're using this on the computer, take a photograph of this, because this is a very important thing. This is my treatment flow. When I'm doing comprehensive diagnosis, and as I said, we analyze the joint on every patient because there's lots of people who are asymptomatic but have joint damage. So our starting in our office is a cone beam. In many countries, an MRI is very reasonable, so we suggest that you get MRIs done if you're doing this type of diagnosis. In the US, it tends to be a little more expensive. Patients are a little more reluctant. We start out with CTs, but our EMG is our very important tool that we use next because it tells us, are the muscles working properly? And if the muscles are working properly, that means that everything else is working properly. We do something called joint vibration that I talked about a moment ago to analyze the joint, and we use the T-scan to look at the teeth. We make a determination. Do they have no joint problems or do they have joint problems? If they have no joint problems, we will treat them with an anterior deprogrammer or in many cases occlusal therapy, and we use the EMG to tell us, did we get the result that we want? The T-scan helps us determine what's going on with the teeth. You can do some of this with articulating paper if you don't have a T-scan, but the EMG is what tells us when we're done. And I know there's lots of questions, how do these work together? These are complementary technologies. The T-scan looks at the teeth, the EMG looks at the muscles, and as I showed you, and we'll show you again, they're interrelated in how they work together. If they do have joint problems, we might do a splint. We might orthodontically extrude teeth. Dr. Diego Tatis, a friend of mine in Cali, Colombia, he loves to extrude teeth to get the new occlusal plane. Or you may treat this prosthetically. But once again, it's the EMG that we use to tell us, did we get the result that we want? And if the EMG is not giving us good data, we're not done. We don't say to the patient, how does it feel? We work to get the good data using the EMG so that we know that we have the best result for the patient. This is just introduction to joint vibration analysis. Patient wears a pair of headphones. These are sensors. They work on sonar technology. If the surfaces are smooth, we get smooth data. If the surfaces are rough, and this is the condyle against the fossa, we get some rough data. It gives us a printout showing us what's going on. This person has bilateral disc displacement, and it gives us a frequency readout. If it's more than 300 hertz in this range, that means that person is bone on bone. When a person has a joint problem, if they have a clicking disc, if they have a displaced disc, the disc displaces on closing so that when they bite together, they might be bone against bone. When they open, the disc pops back into place. And then when they close, it pops out of place. So they're back to bone on bone. And with this technology, I can see that there's more problems on the right side than the left side, and they have disc displacing on both sides. So I know before I walk into doing anything with this patient that they have some disc problems that I need to be dealt with. We don't use this technology, but some dentists do, where they do a jaw tracker, where we look at how does the mandible move in space. The key here, as we can see in these middle two images, is looking at the patient as they open and close their mandible to one side. They've got to have a disc problem. You would want to know that before you start making a crown for this patient. This is looking from above, that they're working to one side. Another interesting part of data. We use the T-scan a lot because we feel this is the best way to analyze what's going on with the teeth. Patient bites into a sensor. It records the pressures in thousandth of a second increments, so we can watch the closure contacts, what tooth hits first, what tooth hits second, what tooth hits third, and it then gives us a relative readout of pressure. So we can see these taller columns mean there's a lot more pressure on the molars, and they have tall pressure here on the cuspid. So we look to see where's the pressure, and there's a lot more data in here. We're not going to do a T-scan course today, but using this data, we can tell how are the teeth fitting together, and then we can determine how to relax the muscles based on where are the contacts. So what are we doing now? We're using articulating paper, and this is what most of us do, and many of us believe that articulating paper is the best way because it's the thinnest and it gives us a lot of data. But this is analog. Do we really know what we're doing, what we're seeing with articulating paper? So I want to show you a couple of studies about how good a job does articulating paper do at marking the areas and giving us information. Now, we've all been taught that big marks mean one thing and small marks mean something else. And is that true? So a group of engineers at the University of Calgary in Canada thought that that was very interesting, that dentists were making determinations of pressure based on color and size of marks. So they did a study where they used an instrument where they could dial in the amount of newtons to the force. They had a set of epoxy models and they marked using Accufilm, which is I think 14 microns. And they were able to get marks on the maxilla and the mandible, all the time. They were able to dial in all the different forces. And here's their data. We see the area. So they marked the teeth with articulating paper. They photographed the marks. They counted the pixels. So they had area, size of the mark versus force. And you can see there's a general trend up of the data showing that more forceful tend to be a little bit bigger. But in reality, if we look at the data itself, this red oval shows that we have all these different forces that are the same size. And the blue oval shows one force, all these different sizes. And we have some that are bigger marks that are lower pressure and smaller marks that are higher pressure. So when they did their statistics, they found that there's a correlation of size versus pressure 21% of the time. I'll say that again. There's a relationship of size versus pressure. It correlates 21% of the time, which means that if we flip it over, 79% of the time, there was no correlation. Now, yes, as dentists, this is an in vitro study. This is in the lab bench, and we use a lot more information and size of mark as we make our occlusal determinations. But the fact is that we can't use what we think is the most important thing, the size of the mark, to be something that makes a difference. And there are other studies that show that this is the same thing happens clinically. So the next study I want to show you is done in 2014 by Dr. Kirstein, who's done most of this work. And he published in Cranio, and he did a study looking at how good a job do we do as dentists interpreting these marks. And so Dr. Kirstein speaks around the world. So he did this at many of his seminars. He had 295 dentists from around the world. And what he did is he showed in his lecture 6 images that looked just like this one. This was one of the images that he showed. He put some numbers on the marks, and he said to the dentists, based on these marks, which is the most forceful and which is the least forceful. And so he used all that data. So 295 dentists, 6 photographs, most forceful, least forceful. So there were 12 answers of these dentists, and he looked at the data 2 different ways. He looked at it, how many years has the dentist been in practice, and how many occlusion courses have they taken, thinking that if you're studying occlusion as a focus of your practice, how does that mean that you're doing a better job? And what he found is that the more a dentist is in practice, the poorer job we do. We all like to think that the more we practice, like I'm in this group more than 20 years, I'm not doing such a great job. And remember, there were 12 answers. So the best person in the study got 7 correct, which is 55%. This is the raw data, but the key here is that most dentists, if we look at years in practice, they were correct 78% of the time, or that 78% of the time they got less than 3 answers correct. So 25% correct, 82% of the time, less than 25% correct. Most of us are not doing a great job. All the studies show that it's all based on interpretation, that ink marks have to do with the thickness of the paper, the type of ink, the dryness of the tooth, the surface of the tooth, and how well it does. This is T-scan data showing that the tallest column, which is the highest for us, is the cusp tip on the second molar here. The lowest for us, which is the shortest column, is on the distal marginal ridge of the premolar. And if we look at the size of this and the size of this, you'd have no way of knowing the difference, the huge difference in the amount of pressure on the teeth. So the T-scan shows us the relative force, the timing, the location. However, articulating paper is very important. And I'm not saying to stop using articulating paper. You can still focus what you're doing on the paper because it shows us the contact, where the contact is on the teeth. And if we go back to the things that I showed you initially, if you remove all the contacts that are on the inclined surfaces, those are going to be your interferences. It's the interferences that are causing increased muscle tension. So articulating paper is still very important, and it is still the key that we need to work with what's going on the teeth. Now, what is EMG? What is electromyography? And this is something I took off the Mayo Clinic website. Motor neurons transmit electrical signals that cause muscles to contract, and EMG uses tiny devices called electrodes to translate these signals into graphs, sounds, or numerical values that are interpreted by the specialist. So the EMG measures the electrical energy in the muscles, and it's going to give us information that we as dentists need to interpret. And this is where Teton comes in. This is the Teton sensors. Very nice sensors. They use standardized this is the sensor, and then this is the transmitter. These little sensor patches are very inexpensive. Patient cost is less than €1 to €2, or less than €1, about $2 per patient to use this particular software. These are reusable, obviously, but that's all your disposable cost. And we're looking primarily at the muscles that affect mastication. And these are things that you're looking at already as dentists. This is our realm, looking at the muscles of the face. So the temporalis, we have anterior, middle, and posterior fibers. The masseter, which is very important in closure. Some of us look at the sternocleidomastoid or maybe the digastric muscles. The other muscles that are important in occlusion are the lateral pterygoids. These are surface electrodes. We can't use these on mucous membranes. If we were to look at the EMG energy in a lateral pterygoid or medial pterygoid, they would use something called a needle electrode. Doesn't sound very comfortable, plus it would infect the arc of closure. So we do this all with surface electrodes. So why are these muscles important? The masseters elevate the mandible. This is what the muscles we use to chew, to bite down, to move our mandible up and down, and they tend to fire together. So we don't see the right side or the left side masseter tend to be fired more, that they're both firing together. There may be an imbalance, but they work together. Temporalis, we talked about the anterior, middle, and posterior fibers. These work independently. The right side temporalis moves the mandible to the right side. The left side temporalis moves the mandible to the left side. This is how we move our mandible from side to side. At the same time, the lateral pterygoid internally, most of us will palpate that, moves the mandible, pulls the condyle forward. There's two bellies to the lateral pterygoid. One attaches to the coronoid process, one attaches to the disc. So when a person has a tense lateral pterygoid, they may have a disc being pulled out of place or a clicking disc. Both sides working together will protrude the mandible, but if one side fires, it pulls the condyle forward and the mandible moves to the opposite side. So these are the primary muscles that we're looking at: masseter, temporalis, lateral pterygoid. At this point, we can palpate the lateral pterygoid. We can look for pressure points, but we can measure the masseter and temporalis. And this is the important part of this: moving the mandible to the side in a lateral excursion, or if they're chewing or bruxing. This is any of these interferences cause the muscles to fire. That there are these sensors that I will talk about a little bit more in a moment that cause these muscles to fire. And so if we have interferences in lateral movements, this creates muscle tension. Once again, the interferences create the muscle tension. So this is EMG. This is the Teton system. What we're seeing here are these sensors again. These are the different printout or the interface that we're going to look at in just a second. What we're looking at here is this is from the TM joint system, which is also made by Teton for dentists who are looking and they want, if they want microvolt data, you can use a different system, a more advanced system, the TM joint system, but it's also a little more complicated. What we're seeing here is the right and left masseter. The patient bites together, relaxes, clenches, relaxes, clenches, relaxes, clenches, relaxes. We're looking to see, are there 4 sets of individual data of the patient clenching? If we look before, at the very left side of this image, we see the resting value. If we look at the end, we see the resting value. In between, we can see that these muscles never get back to resting values. So even though when the person clenches and that sends energy to the muscles and the muscles work, when they open, the muscles don't go back to resting values very quickly because they carry muscle tension. Same patient, exact same time, this is what's going on the left side. You can't see individual clenches. This muscle isn't working very well. It never gets to relaxing value. There's damage in this left side masseter, and it's caused by chronic occlusal problems. So how do we look at this data, and what are we looking at when we see this? And so this is the center of the Teton system. This is the beauty of the Teton system. It's very simple to use. We put the sensors on the face. We have the patient bite down for 30 seconds with cotton rolls between their premolars to calibrate the system. And then we have them bite down for 30 seconds just on their teeth. And we can take multiple data and we get the information. If we look at the right side of this image, we see that all 4 muscle groups, the right temporalis, the left temporalis, the right masseter, the left masseter, are pretty even in their distribution. They're all working evenly. And if we look at the distribution of the forces, it's all around 25% for each quadrant. This is the post-op after the patient has been corrected. If we look at the pre-op, the right masseter is huge. There's a lot of right masseter tension going on. What's happening there that's underlying this problem? Left side is far less. So if we look at the right masseter versus the left masseter, the right masseter is working far harder, has a lot more muscle tension. Left temporalis has more muscle tension than the right temporalis. So we see right away that there's an imbalance, and this is using the Teton as a diagnostic tool. It takes a short amount of time. We do it with the patient in a hygiene visit or a first comprehensive exam visit. We have monitors in front of the patients. We show this to the patient and we're able to tell them, you have a huge muscle imbalance. And this muscle imbalance is cause of what's going on with your teeth. If we look at the lower left, this is the same data, just presented a little bit different way. We can see that the right masseter is far more than the left masseter. And this data shows a lot more information as far as what are the standards in the industry. So this is that same image looking at a little bit more. And these are some of the data points that Teton measures. Now, these are all industry standard use of EMG. And dentistry is just starting to use EMG, but in medicine, it's used a significant amount. And so these are all the different data points telling us whether there's a contact prevalence in the premolar area or in the molar area. Where is it, left or right sided? Are they anterior or posterior? Which way does the mandible move during intercuspation? So if a person bites down and one side comes together first and the second side that comes together second, it's going to cause the mandible to torque. That's torsion. Impact, are they biting down hard or not as hard? This can be related to vertical dimension of occlusion or tired muscles or disc problems. And then how close to clinically correct are they? So if we look at this screen, it tells us pre-op, this is the global index. They're not very good. It gives us a red mark. And this is post-op after they're corrected. They're much closer to ideal. We see here, if we look at these numbers, the percent overlap coefficient of the temporalis, it tells us that they're left-sided. In the masseter area, they're right-sided. In the post-anterior, which is the temporalis, they're left-sided. Posterior, which is masseter, they're right-sided. They're a little more posterior than anterior. And the left side is the torsion is moving towards the left. We see this is what this data is coming from. It shows us graphically, this is the pressure point that the right side has far more pressure, far more muscle tension in the masseter area. And the left side, the temporalis, has far more muscle tension, which is what this shows us. So using just the data that we're seeing here, we're able to see that they're not imbalanced. After they're corrected, we can see they're closer to balance. This is the real world. We never get 100%. We never get perfect. We get clinically acceptable, which in this case is very close to perfect, by adjusting occlusion on the right side in the molar area, which will take the pressure off the right side and bring the balance closer to the middle, and adjusting excursive contacts on the left side, which is going to bring us closer to the middle on the right side. So using this data, we're able to tell what's going on and where we need to focus. If we're looking at teeth, that's one thing, but if we're working on splints or if we're working on sports guards and we're grinding acrylic, it's just as important to be able to get things in the right place and get the pressure in the right places as well. Now, with this, as I mentioned a few times, that there is some unique neurophysiology of the posterior teeth. And as I said at the beginning, in the periodontal ligament space, there are receptors. The fancy word is mechanoreceptors. Think of it as a pressure receptor, that there's a pressure receptor in the periodontal ligament of posterior teeth. I'm talking about premolars and molars. And this is a nerve that goes directly to the central nervous system. Most of the nerves in our body go to a ganglion somewhere, or they go to the spinal cord. But all of our cranial nerves have ganglion that split the nerves out. Now, we work in the world of the trigeminal nerve. And so the trigeminal nerve synapses outside the cranium and inside the cranium. These are nerve fibers that go directly to the midbrain itself, and they go to what's called the mesencephalic nucleus. And this is part of the feedback loop of protecting our teeth so we don't bite down so hard. What happens, and this is a fancy slide showing us that the trigeminal nerve in red has lots of synapses, but these receptors just go right to the mesencephalic nucleus and then the trigeminal motor nucleus. Trigeminal nerve is both motor and sensory, but this is the only nerve in the body that does this. So what's happening is we compress on the posterior teeth. This can be enclosures or excursions, stimulates the mechanoreceptors, sends a message to the brain, sends a message to the trigeminal nerve, and it affects the muscles of the face. So if we have an acute situation, like we bite down on, we're eating shellfish, we bite down on a grain of sand, our mouth opens before we even realize what's going on. That's a muscle reaction in an acute situation. But chronically, depending on the bite, this is what causes long-term muscle tension. So once again, it's these receptors in the posterior teeth that are affecting the muscles that are causing some of the problems that we're seeing. This is the same image that I showed you before, except looking at it differently. Long disclusion time causes long muscle pressure in the periodontal ligament, which causes long muscle activation, and they end up with muscle tension. Short disclusion time, short time pressure on periodontal ligaments, short time muscle activity, less muscle relaxation or more muscle relaxation. So the increased muscle tension causes more energy, and it takes longer times for muscles to relax. As I'm saying, it's how the teeth fit together that affects the muscles, but we can use the EMG to help see this simply and to tell us, are we there? So how does this work clinically? Does this correlate to what we're seeing clinically? So I'm going to show you a few patients. To end this, I want to show you a few patients. Okay, this is a woman who walked into my office, and I've only been using Teton for a few months. And so these are new patients that I've recently seen. And these are things that we picked up on their comprehensive diagnostic exam. And all of the things that I'm going to talk about relate to how we're going to treat these patients, because we will know that we get done when we get the results that we're looking for. So this is a 25-year-old patient who came into the office. She really had no complaints. She had orthodontics when she was as a child, 25 years old, still wears her retainer. And the reason she wears her retainer is that if she doesn't wear it for a few nights, it's hard to get back in. She feels like her teeth are moving. Every once in a while, she gets a little bit of cold sensitivity, but really it's not a complaint. It's just that, I have to wear my retainer because I feel like my teeth are moving. And so we checked her out with the Teton. And what we see right away is that there's an imbalance in the masseters. We're seeing that she's close to 25%, but the right masseter is 32%. The right masseter is elevated. Is there something going on in the right posterior area that's causing a problem? If we look at the temporalis, the left side's a little bit more than the right side, but it's also pretty close. If we look at this information, it tells us in the temporalis area, she's left-sided. In the posterior masseter area, she's right-sided. The barometric or the bar tells us that she's posterior in her biting, and that she's not biting down very hard, 66, because for her teeth are not fitting together properly. She's having a hard time getting her teeth together. The 87 tells us that she's pretty close, okay, but she's not perfect. And so once we identify this to her, she's concerned that maybe this is what's causing her teeth to move. Okay, so we look at her T-scan data, and I know I haven't talked a lot about the T-scan, but as I said, we're looking at relative amount of pressure. So those of you that are not T-scan users, I want you to look mostly at the right side image here. And what we can see, and this is where she's in maximum intercuspation. She's biting down with all of her teeth together. You can see that most of the pressure is in the posterior region, that it's the second molars that are causing the problem. For our international participants, this is an American numbering system. This is the maxilla. All the data I'm showing you, the right side is on the left side of the screen, like we're looking at the patient. So this tooth number 2 would be the 1.6, the 3 is the 1.5, the 15 in the American system is the 2.6, 14 is the 2.5. So these are her molars on the left side, molars on the right side. This tells us it's right side and left side. And we can see that she's pretty close to 50-50, 46%, 53%. So she's pretty close to normal bite, but she's got some problems going on with her molars when she bites together. But as I said earlier, it's the excursions that are really part of the problem. So here she's moving into a left lateral excursion. The mandible's moving towards the left side. What we want to see is cuspid guidance, but she has balancing interferences on both sides in the posterior. And we can see down here, those are the T-scan users, that she's got long disclusion time when she's going to the right side. Okay, once she gets all the way out, she finally gets onto her guidance, but her guidance is on the central and the premolar. So her left side premolar is primary in her guidance. Okay, if we look, and at the same time, it was if I go back a slide, her balancing interference is here on the right side in the masseter area, the posterior. Posterior right, anterior left is where her issues are. As she goes to the right, she still has left-sided group function, and she has some guidance, but she ends up where she has posterior on the same side, on the right side. So if we go back to her T then, right side balancing interference in both directions in the molar area is causing this increased muscle activity in the right masseter area. And she had guidance to the left on her premolar, so she has more activity on the anterior left temporalis area. The T then identified these were the problem areas. If you're using T-scan, yeah, sure, you can find these a little bit easier. But if you're using articulating paper, think about what I said earlier. It's the balancing interferences and the working interferences, the excursive interferences that cause the problems. So with articulating paper, we use 2 different colors. We use the AccuFilm that's red and blue. We put the one color in the mouth. We have them grind their teeth from side to side. Then we flip over the paper and we have them tap straight up and down. So we have our closure contacts in one color. We have our excursive contacts in the other color. We remove our excursive contacts and we keep our closure contacts. We only want the contacts where we want the contacts that we talked about before. Okay, second patient. This is a woman, 55 years old. She had her bite adjusted about 30 years ago because her bite was way off. And since then, she's had headaches and she's had some problems with her teeth. The dentist who did the work did a pretty good job, but she still has headaches, and her headaches are in the left temporalis region. And what are we seeing? Increased activity in the left temporalis region that correlates where her headaches are. Now, her dentist, when he did the adjustment, he removed a lot of posterior contact. And we see that the temporalis muscles are more active than the masseters. But the fact is that's because he created a more anterior bite, which is not a bad thing. It's just where she ended up. But there's definitely an issue with her left temporalis. She doesn't want me to adjust her bite. And let me just go back a second. That first patient, we're going to treat with occlusal therapy to get her right. This patient doesn't want occlusal therapy, but we wanted to find out where the problem is. And here's this, she then tells us she has a problem with her left temporalis area. If we look at her bite, she's got a tremendous amount of pressure on her molars. Okay, we didn't see a lot of molar activity or masseter activity. Her pressures on, or her muscle activity is issues on the premolar area. The dentist who did her adjustment without any technology, for those of you that are T-scan users, can see that she has very short disclusion time. She's very right-sided in her bite. This is her balance point. She's very right-sided. Okay, but if we look at her excursion, she has balancing interferences on the right posterior molar, and she has guidance is on her premolars. It's not on anterior work. So she's got a left posterior group function with balancing interferences. Here she's all the way to the left, and she still has this right contact. It never goes away in the masseter area. Okay, if we look at her movements to the right, she's got a group function going on. She doesn't have anterior guidance. And when she finally gets down to the end, here she has more anterior guidance, more cuspid guidance. So we're seeing is the left side temporalis area is her guidance problem, and the right molar area, but it was more group function on the left side in both directions that caused temporalis activity. In her case, I would like to treat this area. She's decided to wear a deprogrammer, and so she wears a nighttime deprogrammer so that during the day she's careful, she's very comfortable, she doesn't have any problems. But the fact is, we were able to identify, we were able to let the patient know. We were able to let the patient know what the treatment options were before we got involved with her treatment. Okay, patient 3. This is the last patient that I'm going to show you, and then we'll finish up. This is a 65-year-old gentleman who walked into the practice. No problems is what he said. Everything feels great. We put him on the Teton. Look what's going on here. The right masseter is definitely this problems here. Now, he doesn't feel any problems, but at the same time, before I start doing dentistry, I want to know that there's something going on here, because as I do dentistry, I might be able to correct this. Left masseter is also very large. If we look at the numbers, 48% of all the muscle activities, right masseter, 30% is left masseter. This is all going on posterior, and there's a whole lot less activity in the anterior. What's going on here? If we look at the points on this graph, we see that definitely right posterior is an issue. Left temporalis can be an issue, and the numbers show us the same thing, very posterior. If we look at his T-scan, we can see that he's got lots of posterior contacts. Now, this patient had 2 implants on the right side, premolars. You can see there's almost no pressure here. This dentist put implants in and believed that the best way to do an implant is to be able to pull the articulating paper through. No contact on the right side. 65% left, 35% right. He's got very little very little involvement of his premolars. So there's an issue here, huge imbalance. Okay, lots of posterior contacts here. If we look at his bite, we can see that as he's moving to the left, he's got a left posterior group function. He has no anterior guidance. Okay, as he goes to his right, he's got right posterior group function. He's got left-sided, working contacts. That's why his masseters his masseter energy is so high, is that he has all these posterior group contacts. He goes to the right, he never gets off this left molar. So even though we see it's all masseter, because he has very little anterior guidance. And so what we're going to do for this guy is we're going to replace those crowns on the implants on that side, on the left side, to try to increase the pressure on the left side, to give us a little bit better support on that side to reduce the masseter. And we're going to increase his anterior guidance to give him some better balance in the temporalis area. Okay. So this is what we're seeing with the EMG, is we can tell initially that there's problems with the bite, and once we correct things, we have better balance. If we put in one restoration and it ends up like this is a problem. If we do a full mouth and it ends up like this is a problem. But after we dial it in, the Teton will tell us that we've reached our endpoint. When do I use biometric technology? Pretty much in everything I do, because I want to make sure that the dentistry that I do is going to last. If a patient has too much pressure on their teeth, if they have too much muscle activity on one side, they may break the dentistry. They may be causing damage. So we use it all the time with our comprehensive diagnosis, and we use it all the time with our case finishing. We also use it with our TMD patients. Anytime we make a splint for any reason, anytime we make an orthodontic retainer, we're looking at occlusion, we use it. And all of our sports guards, we use this as well. So we can dial this in for getting maximum results. So this is my last slide. I want you also to take some information down here. I spend a fair amount of my time these days working with other dentists, integrating technology into their practice. If you have any questions or concerns, or you're interested in how Teton works, this is my contact information. This is my webpage and my email address. Feel free to contact me if you have any questions. Because this course has been approved by the American Dental Association for CE credit, we would like to get your course evaluation feedback. So you can go to this website, bigskyseminars.com. If you click on course evaluations, there'll be a link for an evaluation on a Google Doc. We request that you spend about 2 minutes or 3 minutes and answer a few questions about how I did. Give me some feedback as far as if you have any questions. Also, you can download a CE document for 1 hour of lecture credit at that same website. And so at this point, I'd like to open up the floor to any questions. Valeria, do you have any questions that have come through?
Okay, so they're writing you great explanation. Is your class are always amazing and good explanation. Thank you very much. Congratulations. So there are coming a lot of congratulations. The first question is about how long does it take to see the improving muscles for the first reports to the second?
It's within a few minutes. When we do occlusal equilibration and we get the results on the EMG, within 15 minutes, they say, my face feels so much more relaxed. I feel so much better. It takes about 15 minutes. If a patient is a bruxer, if a patient is putting a lot of pressure on their molars, the teeth are down in the periodontal ligament space. It takes about 15 minutes for them to float back up into a neutral space. So when we are adjusting occlusion, we do it over multiple visits. We will adjust the occlusion, we'll get better balance, and then we let the patient come home and we see them a week later, and the teeth now have a chance to float into a more neutral space, and that can affect the muscle. So they may leave and say, it feels so much better, I feel better balanced, I feel better muscle relaxation, but they come back a week later, they say, well, now the right side or the left side is starting to move because we have to give the body a chance to adapt to the changes that we make. But to answer your question, we see changes in the same visit.
Okay, thank you. Has there been any comparison of iTero occlusive evaluation with T-scan and Teton?
iTero, as a scanner, we don't use iTero, we use the CEREC, and we find that the CEREC is not really correct. I mean, it gives us an idea as far as what to expect, but it's using computer stimulation technology to try to give us an idea of what's happening. It's assuming that the teeth are not moving, that the teeth are like stone models, that when we actually measure the teeth, when we measure the physiology, then we know that we're getting the result that we want. So there is a correlation, but it's a suggested answer that we still need to measure the actual result.
Okay, thank you. Okay. And what about splint? So how long do you wait before testing the splint? Do you test immediately? And if you find that the splint is not creating a good balance, do you change immediately or do you wait a period of time?
We use the same protocol. We do it immediately and then we have them come back a week later. Okay. Now, if it's a splint they're wearing all the time, if it's a sports splint, we don't have the same situation, but we do adjust it at the time of delivery. We try to get our occlusion right at the time of delivery so we minimize post-op problems.
Okay, great. Another question is about the vertical dimension. So do you use also the EMG value for regulating the vertical dimension?
We use the EMG information for yes, as far as is vertical dimension correct or not. However, depending on our situation, we look at vertical dimension from the posterior. So we look at two things with vertical dimension. We look at EMG data, teeth and data to tell us, are they in a good place? In other words, if a patient's teeth are worn down and they're too low, then as they occlude, the teeth are going to be in a mechanical advantage and they tend to bite down a lot harder. If the teeth are uncomfortable or longer, then the impact is less. But the fact is we find that if people have tooth wear and the impact is high because there's a lot of pressure and there's vertical dimension wear issues, if we go back to our CT and we look at the condyle position, we often find that the condyle is also, or the joint is also collapsed, and they're often a displaced disc. Remember, it displaces on closure. So we don't treat vertical dimension from the anterior, we treat vertical dimension from the posterior. And so we want to increase the vertical dimension both anterior and posterior as well. So we use both the EMG data as well as the CT because there's two different areas of vertical dimension collapse.
Great, thank you. This is a really, really important question. What technology actually guides your occlusional adjustment?
The T-scan guides my occlusal adjustment with articulating paper, T-scan with articulating paper as far as what do we adjust on which teeth where. But the T-then tells us when we're done. So even though the T-scan may give us a perfect result, if the T-then says that our muscles are still hyperactive, we're not done yet.
Great, thank you. And do you use the Teton to design splint for TMJ treatment for minimal muscle activity?
Well, the diagnosis of the occlusal problem is made with multiple technologies, but the Teton alerts us to a muscle, to a possible TMJ problem. But as I said before, the Teton is important both in our diagnosis, but also in our completion of our case, of how we decide to treat that case.
Okay, another one is, can you use Teton for biofeedback?
Not that I'm aware of. So maybe you can answer that question. You're the biomechanics person.
Yeah, I have to say that it's a little bit, it's a spoiler, this one, about the next release, but we will insert also the biofeedback protocol. And in this moment, we don't have a biofeedback part that is installing the Teton software, but I have to say that our users sometimes use it as a biofeedback product, as a biofeedback tool. So basically, they put the sensor on the patient without clicking on the recording button. They just watch the bars that are moving based on the electrical activity of the muscles, or also if they use the other software that Dr. Greens mentioned before, they can use it also, that software. In that case, recording also the EMG signal with a biofeedback process. So basically, they ask the patient to do a specific test, and then they watch the EMG value or the movement of the bar. So I have to say, in this moment, it's something that they do in their daily practice. In the next release, will be also officially insert the biofeedback.
Let me just add to that. Teton is a measurement tool. You know, whatever your protocol is, whether you're using biofeedback, whether you're using tensing technology, whether you're determining where you want the mandible to be, that's all based on other things that you're using in your practice. We use the Teton to determine, did we get it right? You know, is there a problem? And then did we get it right? And if we're able to use it for multiple modalities, that's great. But, you know, in this modern era, we need to use multiple technologies to help us get in the right place and determine where we want the mandible to be.
Okay, thank you. And what is the event code?
The event code, there is no event code.
Okay, thank you. Okay, here, let me see, because I've got multiple panels that I have to watch. Okay. Okay, there. Thank you, Thomas. They are also sending you greetings from Spain, because you know some doctors also in Spain. So thank you for being here, Thomas. Okay. Okay, another question is, what course do you recommend to start?
Well, it depends for what. If your concern is using the technology, then the course would be specific to how to use your technology. So if you're not using technology now and you're starting with Teton, a course would be, how do I use the Teton and how do I integrate this into my practice? If you're looking at using T-Scan, it would be to get some training for the specific software itself. If you're looking at comprehensive, how do I make TMD diagnosis using all the different technologies, EMG, T-scan, JVA, joint vibration, how to interpret MRIs, how to interpret CT, I suggest a group out of the US called it's CNO, Cranial Neurologic, I forget what it stands for, CNO, and the webpage would be cnotmj.com, and they teach how to make the diagnosis and how to use all the software. Unfortunately, they're not using Teton at this point, they're using a competitor's product, but the fact is, how do we use all these things to fit it all together?
Okay, thank you. And comparing Teton and Biopack EMG, which one is more accurate in skewness, kurtosis, waveform length, frequency?
I would say that they're equal, but that the TM joint system by Teton correlates exactly with the bio research, and that you can get all the same data. The difference, if you're doing disclusion time, is that those two companies have written a software bridge so that they are synchronized. If there are many people with Teton, that may be something that we do in the future. And I know Valeria and I have talked about adding, you know, some of the microvolt data to the Teton system for that as well. So at this point, they're very comparable in the two systems, but they are not synchronized as well. I haven't done a lot with the TM joint system for treating these things, but the data is in there. It's just a matter of getting it together. I've been using something a lot lately called the Loretta decompression test, which I'm able to do with either system, having patients bite down differently. I've learned this from Dr. Marcelo Matos in Brazil, to be able to look to see left side, right side, how they together. And using the TM joint system by Teton, we're able to do that exactly as well.
Yeah, thank you. I have to confirm that in the this year we will launch a new release, a software release, in which we will combine the feature of BTS TM joint product, that is our product, which shows also EMG raw data with the Teton software. So we will do a software that will be really including all the indexes and all the data that you can obtain with EMG. Consider that our policy for this year will be to include for every customer all the software updates. So no worry about that, because this year we include all the software updates. So you will have all the software.
The one thing I would like to add is that, to me, patient education is very important. That when I identify a problem with a patient, it's important that they own that problem, that they realize it's their problem, that they walked in with it, that I didn't create this problem as the dentist, that they have the problem. And the beauty of the Teton system is that it's very easy to understand. And so when I put up the Teton images of the imbalance, patients understand. We talked about the bioproduct. It's a lot harder to understand. It's much more, it's for the scientist, for the person analyzing the data. And so it's important to me to be able to show the patient what the problem is. And so even with having both systems now, I like the Teton in diagnosis stage better, unless I'm doing a TMD case, and then I use the bioproduct. But for my recall patients and hygiene, new patients walking in, part of our comprehensive exam, the Teton system is much simpler, wireless, which is really very nice, and it helps the patient to understand right away that they have an issue, and they can walk out saying, I have an imbalance.
Okay, thank you. Okay, do you bill the use of Teton to medical insurance? Have you been successful with this on all the medical plan?
We have done some of that, and we have been successful on some cases. We find that in the US, medical insurance doesn't want to talk to us. We submit stuff to medical, they send it over to dental, dental denies it. So what we found the most success is we're able to document all these cases. We complete the forms that we're using for medical diagnosis, and then the patients contact their medical providers. And we have had some success with patients being able to get their medical providers. And often they'll get a referral from their physician. It's sort of the loops you have to jump through, so that their physician makes the referral, we create the data, we do all the forms, we send it with the patient, and the patients are able to often get reimbursed.
Okay.
But it's not as simple as treating sleep apnea or something like that.
Yeah. Okay, so I think that we don't have more questions. So, okay, the CNO was the Center of Neural Occlusion, right?
The Center for Neural Occlusion, correct. Yeah. And if you're interested in that, that's Dr. Nick Ianios. He's got thousands of video hours on the website to review if you're interested in learning more about that. But he really focuses on using technology. And disclosure, I do work with him, and I do some training on technology for some of his students as well.
Okay, they say that they are following your protocols and also the CNO protocols, and they're fantastic.
So good.
Muito obrigado from Brazil. Okay, thank you. Okay, so if you have any other question, of course, you can also write us, or write, of course, to Dr. Green's email that you can find a contact over there. And Dr. Green, thank you so much. It was so illuminating, this lecture, and was so important for us. So thank you for your lecture, for your being so open-minded, and for considering all this different technology and integrating all this new technique in your daily practice. For us, it's a privilege for us. Thank you.
Thank you, Valeria, and thank you all for coming.
Okay, thank you.